28-year-old woman, 32 weeks pregnant, with the worst headache ever.
Mag.
210 over 120, pulse of 90. Oh, 32 weeks. So that's pretty viable, right? Very much.
Don't stop
How
at South
do we handle that?
Good women and infants.
Women and infants.
Yep, bypass Falcone.
In the meantime, it's about a 30-minute, 40-minute drive. What can we give this woman?
90.
An IV? Nobody wants to relieve her pain?
Well, the concern is you don't want something that's going to pass the placenta and depress the child if they do have to section her.
Mm-hmm.
So I'd be leery of using opiates on her. I mean, I could give her some Tylenol, I don't know.
Medical control.
I would
Medical control?
I would
Yeah.
call
But
that-
why would you not give opiates? I mean, yeah.
Melissa just said. I wouldn't risk that,
Yeah.
depressing the baby.
Well, again, the baby's near term, very more closer to term, so you're not going to harm the baby. It's going to cause respiratory depression in the baby? Yeah. The baby's breathing amniotic fluid at that point. The kid's swimming in water. So again, this is somebody you can treat with opiates. Obviously, you want to get medical control, but you can alleviate the hypertension and the pain by using opiates, whether it's morphine or fentanyl. And again, if you need to use sedatives, that's appropriate as well in a patient like this. All right.
What would you choose?
Sorry?
What would you choose?
I would choose morphine. I'd want to get the blood pressure down. It's got a little bit more anxiolytic properties.
Might last for the ride. Might last a little bit longer for the ride.
Yeah, duration, sure. Okay. 6-year-old with severe non-localized abdominal pain and nausea, no fever. Is that a good blood pressure and pulse for a 6-year-old? Yeah.
Pulse is low.
Pulse is low. Yeah, a little bit. Blood pressure's fine.
I bet he's constipated.
Severe non-localized pain. What can we do for this kiddo? Give him Tylenol. PO.
It's probably going to puke it up.
Yeah.
Probably gonna pick it up. But why else would we want to give it PO or anything PO? Yeah. This kid may be going to the OR, so try to keep everything out. You can give it suppository. Want to give it Tylenol suppository?
That's when you find out these constipated.
But certainly nothing PO. Okay. What else can we do?
You could atomize some type
Yeah, and I would probably use Zofran. I'd probably use an antiemetic first. See if you can alleviate the nausea. You may not do much with pain, but if they're less nauseous, the thing that freaks kids out more than pain sometimes is the vomiting. I know my girls are like that. They have the worst headache of her life, and if she's vomiting, it's like, yeah, it is. So, but again, opiates can be used. I don't think we often do it. We're more concerned with kids. And the reason for having a higher threshold for not giving it is again, you don't want to mask or alter the physical findings when the patient arrives. So, try to keep them calm, maybe give them something for nausea, but I really resort, and other than giving a Tylenol suppository, I would tend to avoid using opiates. Any questions?
Dr. Van Ace, in sort of, sometimes, even in adults, talking about abdominal pain, it's hard to localize, just sort of general all over. Is there a concern with, pain management in that? Just sort of that sort of generalized all over abdominal pain? Do you have any concerns with that, or just treat it like any other pain?
Yeah, if it's poorly localized, to me, that has less urgency in terms of there being an acute abdominal process than if they have localized pain. If they have localized pain, I'm more concerned that there's a ruptured viscus. There's something that's going to go to the OR. If it's non-localized, it's less likely that they're going to go to the OR. less compelled to. And you really want to, in that case, try to match the pain as much as you can, because it's harder to examine a patient like that to begin with. They have localized pain, you give them some opiates. By the time they come in, they're still gonna have that localized pain. It may be a little less, but it's gonna be localized. And that's the key, with patients that come in with abdominal pain. The first thing I wanna know is it localized or is it diffuse? Now, if it's diffuse, that's not always a good thing too, because if it's diffuse and they have peritoneal signs, then that's a surgical emergency right off the bat. But if it's diffuse and it's not peritoneal, it's not worse with coughing, it's not worse with a heel tap, then again, it's not as urgent. We have much more time. Even if they have ischemic bowel, there's nothing you can do immediately in the ER or in the ambulance for ischemic bowel. Any other questions? How we doing? I think I'm about done. Got another slide.